Who wants to break the ice? Chester? Great.
This question is for Gerald Smith. Okay. Are you familiar? What would you say about second molar extraction in orthodontic crowding? You were very clear about bicuspid extraction. I'm wondering your feelings about second molar extraction.
Should be on. Where's the other one, though? We got one here.
Okay.
It's working.
That's okay. It's not. I'm sorry. We'll use this mic because this one's working here. Oops. Speak real close.
Okay, my interpretation, I remember John Witzik back in '79 was a big proponent of second molar extractions. And I think the reason why he went that way is because with acrylic covered palates, you could not get the expansion that you can with the ALF. And when you look at the arch form, the widest point on the arch is at the second molar point. From my perspective, you don't want to take those out. If need be, you can always go to a third molar extraction. With the ALF appliance, you will be amazed at the amount of expansion that you can achieve. And I think Brendan will back me up on that the difference between the rapid palatal and the acrylic on the palates compared to the ALF, there's no contest. Right?
Are you looking for affirmation?
Something like that. I thought I paid you before we came here. Got my son, okay. But from my clinical experience, I've had patients that went through rapid palatal expansion and have failed, Schwartz expansion have failed. We get in with the ALF because we're taking the torques out of the skull and we can get a lot more widening. So I think it's obsolete to do second molar extractions personally.
What do you recommend then? Just strict expansion period? Or
what we're finding is that if you look at most dental arch abnormalities, it's usually between the intercanine area. The premaxilla is locked up, but yet when you look at your conventional expanders like the NiTi type things, where are they hooked up? They're hooked up on the molar, and they have anterior lingual extension arms that are expanding the bicuspids. That's not where the problem is. The problem is the premaxilla is locked up, and the only way you can free up the premaxilla is expand the intercanine space, which unlocks the malar or zygomatic bones. Then you get arch expansion. But if you don't do it intercanine, it's not going to happen. It's a cranial issue. It's not just a muscling teeth apart. Take my course. It's on the internet. We give them at the office. I've given a few up in Toronto. It's powerful stuff. It makes orthodontics easy. I mean, literally easy, because it creates the space. Then all you have to do is jiggle the teeth in, and you're done.
Thank you. Another question, Chester.
Brendan Stack, the last slide you had was a website, and I see a video, but it was just flashed up and it wasn't there long enough for me to write it down. Do you remember what that website was, where we can see that CE video?
No, but
Just 1 second, I'll get.
no, I don't. But if anybody has that information, they could just shout it out. It was a person who, a company that produces my DVDs. We have a whole set of DVDs, 44 hours, that's available. And you can just order them. I think it's orthodontic. Well, it's Rideau Manufacturing Company. It's the largest dental lab in Canada.
Exactly, yes. That's what I heard as well.
Try it again.
Orthodontics.com or .ca? Orthodontics.ca.
Is it S, plural?
No S.
Tick, yeah. Orthodontic.ca.
Makes a big difference.
Yeah.
1 degree. Difference
.ca.
between steam and hot water.
.ca.com.
.ca.
.ca, period.
Oh, okay.
It's in Canada. .ca.
Thank you.
Great. Whoops, this one's really loud. Sorry about that. Any other questions for our panel this afternoon?
For Dr. Stack, how young do you start treating the Tourette's patients? Age 7?
Yes, as soon as that's when the symptoms develop, as soon as they walk in the door, really.
And how do you interface with orthodontics in combination? At some point, you need to change their occlusion so that they're opened more? Did I get that?
Yeah, all of these cases are two-stage. One stage to treat the symptoms and the internal derangement, which changes the maxillomandibular relationship, which is off to begin with, which is why they're symptomatic and impaired. And once the maxillomandibular relationship has been changed, then you move the teeth, which are really like 32 little buttons on a trumpet, to hold them. It's that simple.
Okay. And one more thing. Does this change the spewing of obscenities in Tourette's patients?
Coprophagia, yeah, dirty talk, potty talk, whatever they call it. Yeah, gets rid of that. It gets rid of ADD, ADHD, all that stuff.
Interesting.
Fascinating. Thank you. Anyone else has a question for our panel? If you come up and ask your questions, one can hear, Norm. Thanks.
The child is 14, right, and he has mild Tourette's. Do you still want the vertical dimension open? What's the amount?
Oh, 40? No, they don't end up there. It varies. It varies. Once the internal derangement is reduced, and I'm stressing that on purpose, because a lot of you guys are just going to go treat the symptoms and think it's done, and it's not. Once the internal derangement is reduced, then you just lower it right away, down to where the facets of their teeth line up if they have facets of their teeth, things like that. I mean, the teeth touch.
Good, thank you.
Thank you, Norm.
At most, they might be left with 3 or 4 millimeter posterior open bite. You just extrude the teeth.
I have a quick question for Dr. Grant concerning vitamin D studies, long-term studies on possible hypercalcemic problems. I know there's one study that showed for 6 months, 10,000 units a day didn't cause any problems, but are there any longer-term studies to reassure us that long-term high doses would not cause any problems?
I'm not sure of that, but there is a nice paper by Hathcock and Veith looking at the adverse effects of high doses of vitamin D, and they found that there's 1 or 2 papers at 20,000 IU per day over long term, and then at 40,000 IU per day and above is where the problems start.
Okay. Thank you. So at 10,000, looks pretty good.
Yeah, that's physiological dose.
Great. Sorry, there's a question here, then Steve.
Thank you. Dr. Smith, I have a question about the implications of very early life difficulty in synchronizing the suck-swallow-breathe synchrony for young infants and children, and the implications that has on tongue placement in the roof of the mouth and all the oral development from there in terms of some of the work you're doing.
Well, all I can refer to is Viola Fryman's study of 1,250 newborn babies, and 80% of them had cranial distortions. From what I'm seeing is when, if you're trying to train the tongue, it's a circus act. It's the only muscle in the body that has an origin and no insertion. And if you don't have the cranial balance and the neurologic balance of the cranial nerves, you're not going to get function. Straightening the cranium does a multitude of things. It rebalances the autonomic nervous system, and it creates the space for the teeth and the tongue to work properly. It's amazing the changes you're going to get. And the reason why a lot of these changes aren't being made is because people are just not getting to the core issue. The core issue is the cranial torsions. If you take them out, then everything seems to fall into place.
Thank you.
Dr. Coral.
Thanks. I have a couple of questions for Dr. Stack. What happens after surgery in your cases that you showed this morning? Do they still end up needing occlusal support and splints?
Oh, They wear the splint for approximately 8 to 12 months post-surgery. They're given an exerciser called a therabite, which they use. They then go into being occlusally restored either crown and bridge-wise or orthodontically.
Okay.
But they'll end up with the mandibles suspended below the cranial base and more forward, so they'll have a posterior open bite.
Then my other question was, what do you do with kids if they have an early onset, that 7-year-old onset of the syndrome? I mean, what kind of do they have displaced discs at that point, or is there some other kind of occlusal manipulation you can do in that early stage?
Well, you can try and get the discs in place with a splint, or you can put them under sedation and manipulate their mandible. You can inject the joint and manipulate it. Have you ever seen these deciduous dentitions as flat as your glass slab, all ground off? The disc is out of place on those kids. We've done studies on that. It's just, and the kid might be 4 years old, 5 years old. Don't think this is a middle-aged problem or an old person's problem. And so what are you going to do with those kids? And so we get the disc in place. That's the main thing that we do. And that gives us long-term stability. It's our best hope.
Thanks.
Question back here. Dr. Wilson.
I have a general question. Dr. Stack, I'm sure others may wish to comment too, regarding the use of the dental splints, such as the Somnomed, that's used for pulling the jaw forward and improving sleep apnea and mild to moderate sleep apnea. Comments about how the long-term effects of using that type of device in patients for whom they either don't tolerate or are unwilling to use a CPAP machine for sleep apnea.
Well, it causes changes in the occlusion. You have to inform the patient about that ahead of time. I think a lot of these people with sleep apnea have an underlying TMJ problem, but it's not picked up because you don't MRI the patient, because you don't even know how to write an order for an MRI. All you have to do is take your little prescription pad and say, please take an MRI through the left and right TMJ and send it out. And you get it. And you'll be amazed at what you see. That's why a lot of these sleep apnea appliances which advance the mandible worsen the patient. Have you ever noticed that? Some of them come back 3 days later in severe pain because they have an anterior displaced disc that sleep appliance has advanced against the capsule, causing an inflamed capsule or capsulitis. And the patient has accused you of injuring them or causing a problem. And what you've done is taken a pre-existing quiescent problem and stirred it up because you didn't know they had the problem. You thought you were working on an asymptomatic normal patient. You were working on an asymptomatic abnormal patient. See? And so that's the problem right there. I think most of them have an underlying internal derangement. And a lot of times, just from a strictly TMJ point of view, if you treat the internal derangement, the sleep apnea goes away and you don't even get into that phase of it.
Thank you. Questions? I'm going to intervene here and ask one general question. It could be Dr. Smith, Dr. Stack, or anyone. When I graduated 35 years ago, I used to do 2 mouth guards or 2 night guards a year. Now I do 2 a week. Any hypothesis as to what has happened to our population that's developing, or am I just seeing more cases because I'm more aware of the symptoms, or do we actually have much more grinding and clenching going on than we did 30 years ago? Any opinions?
Well, the population is much more toxic today than they were 35 years ago. And an interesting case that was brought to my attention by one of my patients was a TMJ situation. And she then disappeared from the practice and 3 months later came back for routine examination. And she said, my TMJ symptoms are all gone. I said, what happened? She said, an endocrinologist picked up that I had hypothyroidism. Believe it or not, people, you have more hypothyroid patients than you can imagine in your practice. Why? It's real simple. Chlorinated water, brominated bread from bleaching, fluoride in the toothpaste and the water, mercury, hydrogenated fats, all suppress the thyroid. When you have a weak thyroid, you have weak muscles and ligaments. It sets up for strain problems, chronic TMJ problems, chronic everything. The thyroid is one of the key endocrine organs of the body. And they have all these new diseases because of that. Raynaud's disease is nothing more than hypothyroidism. A lot of these mental issues, nothing more than hypothyroidism. Even tooth decay, believe it or not, you look at Eugene Hertog's original research from Belgium, an MD back in the 20s. Decay in your adult patients, hypothyroidism. Young children, hypothyroidism. So to answer your question, the grinding and clenching, we're structurally more out of balance and more toxic than we were 35 years ago.
Of course, the other side of that is we have less iodine in our diet. For example, I think the bread manufacturers replace iodine with bromine. We're using less iodized salt. So I take 2 drops of iodine and a little tincture every day.
One thing I might add is the very great importance of cranial dural strains. I've always thought it was important. I've always tried to eliminate them. I had a patient recently who we treated, I thought, very successfully. She was from Norway, and she went back to Norway. And 2 years after we treated her, I got a phone call from her family, and she was in a hospital with all kinds of head pain. And she was in the hospital howling like a wolf, they said. And no one knew what to do, so they were just calling around asking me and what the previous treatment was, and I told her, and they were calling other healthcare practitioners. And all the neurologists and all thought she was nuts, thought she was crazy, denied her treatment, didn't know what to do. And it had happened because a week or two, or maybe a month before, she had had braces applied to her teeth, and the guy put in vertical elastics, 1 or 2 on each side, and that triggered everything. She was asymptomatic and fully functional prior to that, and that triggered all the problem, and she killed herself.
Ah, good.
So we're all kind of depressed about that. But I'd like you to be highly aware that your actions all have consequences. Even the actions that you take in the best of interest of your patients, they still have consequences.
Fantastic. Thank you very much. Questions? Dr. Matt Young.
Okay, thanks. I had a question about the Sirona 3D pan. How do you decide, well, first off, does that machine take a regular pan as well as a cone beam or not?
No, it really doesn't. I've got a pan sitting in my office, and I don't think I've used it in a year and a half.
Okay. We were discussing during the break, how do you determine who walks in the door, who you would take a cone beam on, and who you would take
my
a pan
new
on?
patient exam is 1 CAT scan and 4 bite wings.
Okay.
That's for everybody, because I don't know what's there till I look at it.
Well, many members here, as well as I did, I probably did 1,500, 2,000 topaz tests where we could actually test for the toxicity of root canals, and it was remarkable how many patients would come back on recall and say, you know, the one you topaz that was off this chart is starting to hurt me now. Yeah. And now that we don't have topaz, it seems to me that the cone beam would be an excellent diagnostic tool to decide which root canals to extract if the patient had to put it off for a while. And then what would you do in a case where you did see a lesion on a molar like that and the patient said, well, it's not really hurting me, you know, what should I do? Do you have a sign release, or where do you take it from there?
I think the patient always has the option of treat or not treat. In fact, one of the things I often say to a patient when I find an abscess of whatever size, you have 3 choices. You can do nothing, you can have a root canal done or redone, or you can have it extracted. And I don't have them sign a release, but we always write in the chart that they were given those 3 options. and then they get to choose those. For me, at least in my conversation with them, I kind of want to know what their health is like, and I don't think anybody personally should keep an infected anything on their body. So, they get a choice, but my experience has been the sicker they are, the more interested they are in not having infections. That's what I find.
Is it also your experience that the cone beam would run about twice the price of what a pan would be across the country, do you think?
You mean as cost to the patient?
Right.
That's been intriguing. And just be quite frank, I started off at $300 per CAT scan. There was a imaging center that came into our town, and so I've dropped the price to $200 because it doesn't really matter what I charge for that. I could give it away and still economically the whole thing makes sense. And one of the things I tried to stress is, this is a moral issue. No, I can't give away diagnostic things. I can't give away dentistry, but I really don't think it matters much. If we all lose money on exams. So, if I can just get somebody to do a CAT scan and a thorough exam, one of the things I find with the CAT scan is they don't go looking for a second opinion. They're so convinced that you're the office they should be in so it doesn't matter. So I don't think the price matters personally.
Comment on your with the diagnostics on those root canal teeth. You could use Dr. O'Mora's O-ring test, direct resonance testing, and you could pinpoint the pathogens that are present in that tooth. I myself have a couple root canals in my own head, and I use RIFE technology, R-I-F-E, on a weekly basis to keep the infections down. And you're caught between a rock and a hard place. The more posterior teeth you lose, the less cranial stability you have, which sets up more problems. But if someone has some serious illnesses, I'd get them the heck out.
Questions? One more. I'm sorry. Leo.
This is more for Dr. Colpitz. I know that you have had Cavitat. I don't know if you still are using it. How does that compare to the cone beam, the CAT? And you've had a lot of experience with everything. Just comment on that if you would.
Sure. The Sirona has a icon where you can pull up and get bone density. You can pull the little cross up and you can lock it on any of the images and it'll give you bone density. Now the problem is that bone density is arbitrary. For instance, the number may go from 1,700 down to 1,100, and that's just arbitrary of just how dense is the bone. I really thought when I got it that I would be happier and it would be more accurate as far as diagnosing Nico lesions or cavitations. It hasn't been as accurate yet, and it may be that we just need a lot more people looking at it and coming up with some sort of a criteria. My rule of thumb is my observation has been is if it gets down into the 1200s, then I think we've got something. I still use the Cavitat occasionally. I think there's an incredible potential for looking at something with a traditional instrument that has bone density for it. I've got a Cavitat and I use it. Some guys have really taken some heat from that unfairly, in my opinion, but that's the real world we live in. So I use it. I haven't been blown away with it. If I get some things that that look at bone scans or the bone density and it doesn't look good, honest, at this point, sometimes I'll say, well, let's run a Cavitat on that and see if it confirms it. And so far, it's been pretty good, but I haven't let go of that yet.
Thank you.
More questions?
I had a question since I'm right next to Maury.
Richard.
For Dr. Friedenfeld, you mentioned that there were some problems with bottled water and talked briefly about some possible solutions for that. Could you go over a few of those tips or pointers that you may have for us in terms of getting better quality water to our families at home and to our patients in the dental office?
Yeah, the best quality water is really your tap water. As I said in the talk, your bottled water is regulated by the FDA, which has much lower standards than the EPA that regulates the household water. Now, some communities have more toxins in their water supply, and there are resources where you can go and investigate what exactly is in your locale's water supply. And if you need more specialized filtration than a simple carbon filter, like a Brita filter, that you can get more specialized filtration. And in that resource guide that I talked about, there are lots of options, or there are ratings for different filters, what they are useful for, what they're going to filter out, and you can identify which filter is best for you. But your best source is your tap water.
What if it's fluoridated?
Then you use a chlorine filter. The chlorine becomes a problem more when you are showering than when you're drinking.
I think the question was fluoride, not chlorine.
Oh, fluoride. I think the fluoride does come out with the carbon filters. I may be wrong on that, but when I checked for it, I thought that it was coming out.
No.
And I'm seeing head shakes. No. So then you guys got to help me with that. Well, the fluoride, the RO will take it out, yeah. The only problem with RO is that most systems are wasting 2 gallons for every gallon that you produce. So it's very wasteful for the land. But if that's what you have to do, then that's the option.
While you're still on the mic, what was the web address for the resource guide?
www.stockton, STOCKTON, F as in Frank, P as in Peter.com. Go to educational material, and their resource guide is there. It's currently a 5-page downloadable guide. And there's other information on there. People had asked about the calculations for how much mercury is coming off of current dental amalgams, and other stuff that I've written about mercury toxicity.
Question up front. Great. Or comment.
What's your feeling on the fact that they're picking up like approximately 66 different medications in the public water supply?
You're right. The water supply, our water treatment centers are able to remove what they know about. So large molecules will come out with their with the porous filters that they use. Smaller molecules, they're going to remove them if they know about them or specify them. So a lot of stuff is getting through. But a lot of stuff that we're concerned about, like the chemicals that we take in our bodies, the antibiotics, the chemotherapy drugs, these are not just found in our local water supply, but they're found in animals that live deep in forests, way away from human exposure. So it's out there. There's only one water supply. It's only one aquifer, and it's all connected. So getting your water bottled in Fiji and shipped over here in heated boats doesn't make it a safer water supply.
Gee whiz. Thank you. More questions for our panel? Yes.
Dr. Stack, I was a few minutes late, so I hope I'm not being repetitive, but what I heard you say in your lecture a couple of things. You talked about the anterior displacement. You also talked about the tongue reflex being a precipitative, whatever. Which one of those both, are you seeing more with patients? And I guess also, do you ever have a patient that'll come in that has a relatively healthy joint but might have some other factor that can lead to their symptoms?
I'm not aware of it. Most of them it is internal derangements they come in with. That's what we're checking for all the time. I practice right next to an MRI imaging center. The guy who reads my x-rays is the chief of radiology at National Institutes of Health, NIH. He's the premier radiologist in the United States. We get a very detailed report over the signature of a very strong man, not just some fellow who got out of medical school last week. We always know what we're dealing with. It's never my opinion. Everything I've told you this morning, I can document. Everything is documentable. I gave up flying by the seat of my pants 30 or 40 years ago. We're always looking for the prime cause or the first cause of what the problem is. We don't treat the symptoms. We're not a Dr. Feelgood. Although Dr. Feelgoods populate the healthcare profession and they make lots of money, I look upon them with disdain, and I don't want to be one. I used to be one. I no longer am. I think the drug dealer on the corner has a better drug than most of dentists and physicians. He's got a drug that is cheaper, quicker onset of action, lasts longer, more profound effect, longer duration, and a drug dealer's got you beat 10 different ways to Sunday. And if you're not better than a drug dealer, go sell antiques with your wife. That's my attitude. I'm sorry. So I always want to find out what it is. I want to fix it. I want to fix it permanently so it stays fixed. And the only excuse that I tolerate that it doesn't stay fixed is because a patient got in another motor vehicle accident, got in another beating, got another trauma. But otherwise, I want it to stay fixed. And I consider anything less than that a personal insult to myself, in my mind. That's what drives me on. And so, to answer your question, on all these patients, I look for an internal derangement. And I always find it, because I always document it with the MRIs. And I don't use things like do a 10-second exam on a patient and say, oh, it's within normal limits. And you see on these charts that you review from these other healthcare providers, WNL, all the time. I think that's the most insulting thing people have ever learned to write. And I'm just not there. I'm marching off to a different drummer. That's just me. See?
On the tongue, the reflex you said with the tongue, is that something that you can, I mean, I don't guess you really screen for it, but like tongue position, size,
NIH has come out with a study with 6 different reflexes. The genioglosal muscle reflex, and so on. And I got into that about 4 or 5 years ago because there's some general dentist in the Tacoma, Washington. If someone will sing out his name, do you know? Who?
Tacoma.
One who does SOD?
No, he's a dentist out there, and he's mainly Crown and Bridge, but he doesn't have a master's in Crown and Bridge. He's just a general dentist. And he works from behind the patient on the right. And he noticed, in working on these patients, that if the patient was missing a first molar, lower right first molar, the tongue flowed into that space, right? Which makes sense. And if he was missing a second bicuspid in the first molar, more of the tongue flowed into that space, and it would flutter. And the patient would have pain on the opposite side of the face. And he saw this patient after patient after patient. Well, I've been looking at patients for years too, but I never noticed that. But he noticed it. So he started to fill in that space with, I guess, a glob of wax or something like that, and made the pain go away while the patient was in the chair, at least temporarily. And so he gave a course that I went to on the lingual surfaces of teeth. Have you ever heard of a course on lingual surfaces of teeth? Never. Always on the occlusal surface, sometimes on the buccal. Okay, thank you. So that has great significance, I think, to dentists. It depends whether you use a ridge lap ponic, sanitary ponic, just run a steel bar across the gap as a space maintainer. And I was sitting in this class and I said, why? Because I'm an orthodontist. I says, I could design flanges on these retainers to accomplish what he was doing. And what he was doing was elevating the base of the tongue and taking the epiglottis and moving it forward like that and opening up the airway, just unblocking it without even trying to move the mandible forward. And so I was just astonished with these revelations I was getting from this guy in class. And so that's what we do. I hope that answers your question. You know.
Hey, thank you. We'll take one more question, and then we'll go on to Friday night movies. Anyone?
Up here.
Up front. Go ahead.
Just about CAT scans, and let me just set the question a little bit. We've known in medicine for a long time that Looking at spines and seeing bulging discs we used to think that was the cause of sciatic, of radiculopathies. We know now that the frequency of bulging discs is the same in people who have back pain and those who don't. Looking at knees on CAT scans, we found that for a long time we thought that these torn meniscus we would see in 70, 80-year-olds was a cause of a problem that needed to be treated, and people were getting surgery, until we found that there was no difference in the frequency of disease, pain, problem in those who had these findings on CAT scan and those that didn't. When you're doing something now, you're taking a CAT scan and you're zooming in and out and getting really refinement of your view. You're seeing things that nobody else has seen before. How do we know that what you're seeing is pathology that needs to be treated?
No, I think that's a great question. I think one of the things you need to do with every patient is look at that patient, not just one tooth. I think because sometimes coming up the side of the tooth there'll be some nutrient canals, and so the bone will be less dense on one side, and it can fool you. But I think, like what I tried to show today, is some of those lesions are pretty significant. And why doesn't the bone grow next to a tooth? I mean, it should. That's what it's supposed to do. So I don't know if that answers your question, but one, I think you always have to look at a healthy tooth, or what you think is a healthy tooth, or look at the others. And a lot of these lesions that I see have to do with root canal treated teeth. Not all of them, but a lot of those that are subtle. And so, we're already looking at something we know has a high failure rate. So I don't know if that answers your question, but I'd like everybody in this room to get a CAT scan. In a year we can sit down and look at this together, because you're right. Sometimes you're looking at things. Sometimes I spend a lot of time looking at those CAT scans because sometimes it's new territory. And I think you look at it. And I think one of the things I tried to say today is it's okay to not know. Sometimes you have to say, I don't know about this one.
Have you ever found a lesion on the CAT scan and done a pulp test, for example, and found the tooth to be alive and had to make a decision?
I don't do an awful lot of pulp testing anymore. What I worry about is, particularly in a molar, my goodness, you've got 2 or 3 roots, you've got a big nervous system. You don't have to have much of that tooth to still be healthy.
That's right. To get a response. Teeth, that would be a contradiction.
So I don't know if that answers your question.
Thank you.
Does that CAT scan show the TMJ?
It does. It doesn't show soft tissue very well. And so, I have some, Brendan's looking at an MRI, so I don't use that particularly very well. Are we about done for the day?
We're done.
One of the things that I started to say today, and I got busy and I didn't. Boyd Haley's been a friend of ours for a long time. And he used to, when he lectured, he would say, I was a line medic in Vietnam. Most of you guys don't know what that means. Boyd Haley was a combat medic, and he's one of my heroes. And he took care of troops over there, and he takes care of us here. So, I don't want to say that in front of him. I don't see him here because I don't want to embarrass him. But you guys need to know that this guy's a hero and one of my heroes.
He is. Thank you so much for mentioning it, Dr. Colford. Thank you to all our panel. Thank you for the excellent conferences you prepared and delivered today. You have elevated the level of our knowledge. Thank you so much, and very practical things, all of you. Thank you so much.